Maybe.
Yeah.
Sure.
So then you don't need me to share the PPT because you'll be having her introduction in mind, no, sir? You know her.
Yeah.
Dr. Natesh, you can start 1, 2, 3, 4 and then start it, or you can start recording yourself, whatever is comfortable to you.
Okay, in that case,
should I?
Yeah, we can start recording, sir. Please proceed recording.
So should we start?
Yes, sir.
Yeah.
Right. So we'll go with the countdown.
Yeah.
5, 4, 3, 2, 1.
Yeah, Natesh.
Good evening, everyone. Good evening. So it is a pleasure to welcome you all for this August Journal Club of Indian Stem Cell Study Group. And today is very special because we're having our first session on regenerative ophthalmology. This region ophthalmology, many would have not heard about because there are many things coming ahead. And we have one of the experts for us, Dr. Gauri Madam from Arvind Hospital. She's an expert in the field of glaucoma research, stem cell biology. She's also a scientist in Arvind Hospital. And I welcome you all for this program. I welcome Avi sir for the moderating session. And I thank Manish Khanna sir for giving the opportunity for us to do this program. Avi sir, you can introduce Madam, you can start the program, sir.
So a small introduction about the speaker. Dr. Gauri Priya is now the chief scientist at the Aravind Eye Hospital at Madurai, where they have got a separate building with beautiful lab, lecture halls, where they do extensive work for the past almost 20, 30 years in Madurai. And the basic work which they are doing at Madurai is being applied clinically. The first application came out for the limbal stem cells. They have done extensive work on limbal stem cells. And today, limbal stem cell therapy is being done throughout India in multiple centers because it is adopted by many of the cornea surgeons. So corneal blindness eradication is one of the goals, primary goals of any government, whether it's a state government or central government. They have the corneal blindness eradication program, and whatever success, India is one of the leading countries in conducting this program and eliminating corneal blindness with the help of limbal stem cell therapy. And as I said, the basic work being done by Dr. Gauri Priya and team at Madurai, and similarly several teams at LV Prasad Eye Hospital, Narayana Nethralaya, and all these tertiary eye care hospitals are contributing to this. Today, Dr. Gauri Priya is going to talk on the trabecular meshwork stem cells. She herself is a PhD from Madurai Kamaraj University, and her teachers probably Professor Periyakarpan and Professor Dharmarajan. They were the pillars of this Arvind Eye Hospital Research Institution, and both of them belong to Madurai. And then they have created a very big team of scientists, including Dr. Gauri Priya, who have taken up this research on ophthalmology in general. Their work spans from the cornea to the retina. And today we will be very happy to see what is the work which Dr. Gauripriya and team has done for trabecular meshwork. Over to you, madam.
Thank you, sir. And I'd like to thank all the organizers for giving me this opportunity to present our work. So the base paper for today's presentation is the one that was published this year on transplantation of human trabecular meshwork stem cells induces cell proliferation and intraocular pressure reduction in a cell loss model of glaucoma. So before going into my presentation, as sir said, the focus of our research had been on adult ocular stem cells. So it is Professor Muthukarpan's vision what we are today, and he strongly felt and he instilled in us that understanding the basic biology of these adult ocular stem cells are most important because Only if we understand the basic biology, you can develop better cell-based therapy. So this was the period when people were talking more about pluripotent stem cells than adult stem cells. So our focus of research is mainly on locating where the stem cells are there in various tissues in the human eye, what are their characteristics, what is their role in maintaining tissue homeostasis throughout life, and what are the molecular mechanisms that regulate the fate of these stem cells. And are there any changes in these adult tissue resident stem cells with aging and in disease condition? So only when we know all these basic details, we can check whether they can be used in regenerative medicine. We had been working on the limbal epithelial stem cells in relation to limbal stem cell deficiency, wherein we cultured these autologous limbal epithelial stem cells and used them for transplantation onto patients. And we also worked on limbal stromal stem cells, and we demonstrated for the first time that in a limbal stem cell deficient patient, it's not just the epithelial stem cells, but the stromal stem cells are also affected, highlighting the need for transplanting both the stromal as well as epithelial stem cells for these patients. The next one is on trabecular meshwork stem cells in relation to glaucoma, which I'll be talking today. We are also working on lens epithelial stem cells in relation to cataract and retinal pigment epithelial stem cells in relation to age-related macular degeneration. So with reference to trabecular meshwork stem cells, the trabecular meshwork is a tiny porous tissue that is located at the iridocorneal angle of the eye. So it is a sieve-like structure. So you can see the cells here on the trabecular beams, and these drain the aqueous humor that is produced by the ciliary body. So the aqueous humor is produced by the ciliary body, and it enters from the posterior chamber to the anterior chamber. And from here, it is drained through the trabecular meshwork, and then it reaches the Schlemm's canal, and it's finally drained through the episcleral vein. So when the aqueous humor passes through the trabecular meshwork, the trabecular meshwork cells phagocytose the debris that is present, and thus it maintains the normal intraocular pressure. With aging, a reduction in trabecular meshwork cells has been reported. In glaucomatous condition, that is the primary open-angle glaucoma, there is a drastic reduction of TM cells compared to age-matched control. So this results in reduced phagocytosis, accumulation of extracellular matrix. So here you can see that compared to the normal, there is a thickening of the beams, and this leads to blockage of the trabecular meshwork, thereby resulting in an increase in the intraocular pressure. When the pressure in the anterior chamber is increased, then automatically the posterior chamber is also affected, which affects the optic nerve. So you can see the optic nerve head excavation, the RNFL thinning. So because of this, this leads to irreversible loss of vision. So this is called as primary open-angle glaucoma. And the current treatment is lifelong use of drugs to reduce the aqueous humor production or enhance the outflow, or to increase the outflow by surgical intervention. So that's when people started looking at the cell biology. So the presence of stem cells in the trabecular meshwork has been demonstrated earlier also. So people have identified the presence of stem cells based on the phenotypic marker expression ABCG2, Notch1, OCT34, ANG-G, mucin1. And they also demonstrated functionally that when there is a trabeculectomy that is done, then there is an active proliferation of cells from this region. So here, if you see the trabecular meshwork, you have a filtering region as well as a non-filtering region. So the aqueous humor is filtered through these meshwork, and it reaches the Schlemm's canal. And the stem cells for this meshwork reside in the anterior non-filtering region or the Schwab's region. So people have demonstrated when there is a trabeculectomy done here, so the cells from this region, they proliferate and then they repopulate this filtering region. And people have also shown the presence of label retaining cells, that is the long-term BRDU retention in the Schwab's line region in primate eye. So these indicated that the stem cells are there in the anterior non-filtering region. Except for this functional study, not much is known on the biology of the human trabecular meshwork stem cells. What is their role in maintaining the stemness throughout life, and what is their status in glaucomatous condition? So this is what we addressed. So we used two markers, the universal stem cell marker ABCG2, as well as the neural crest-derived stem cell marker P75. So here the ABCG2 appears green and P75 red, and PI, the nuclear counter stain, as pseudo-colored blue color. So here if you see, compared to the filtering region, the expression of ABCG2 is higher in the anterior non-filtering region. Similarly, if you look at the P75 compared to the filtering region, the expression is very high in the non-filtering region. So when we combine both, overlay both, you can see clusters of cells that are tightly coiled among themselves to be positive, double positive for both these markers, indicating the stem-like cells are present in the anterior non-filtering region. We also did additional analysis wherein we isolate the trabecular meshwork cells after collagenase treatment, and then we analyze for the expression of these markers. We have earlier established, based on our experience in limbal epithelial stem cells, that high expression of one of the markers, either ABCG2 or P75, along with high NC ratio to identify these stem cells. See, this property of high NC ratio is again unique to the stem cells, but not all cells with high NC ratio are stem cells. So therefore, we need to use two parameters, either ABCG2 and P75 or ABCG2 with nuclear cytoplasmic ratio. So here you can see a small proportion of cells to have a high expression of ABCG2 and high nuclear to cytoplasmic ratio. Such cells were also positive for P75, and they also were positive for the trabecular meshwork markers chitinase like 3-1 and aquaporin 1. So we demonstrated that there are stem cells in the trabecular meshwork. And having demonstrated that they are located in the anterior non-filtering region, we also analyzed the tissues, donor tissues of different age groups. So less than 30 years, 30 to 60 years, and above 60 years. So you can see that with aging, there is a reduction in the percentage of cells that are highly positive for ABCG2 as well as P75. And this was significantly correlated with the total cells that are there in the anterior non-filtering region. So this indicates that there is a significant association between the stem cell content and the TM cell count that are there. So with aging, there is a reduction in both. So this is the first demonstration that with aging, there is not just the loss of trabecular meshwork cells, but there is also a reduction in the trabecular meshwork stem cells. Then we wanted to analyze what happens in a glaucomatous condition. So we had 4 donor tissues. So all these donor tissues are obtained from Rotary Arvind International Eye Bank and from the Eye Bank of Tirunelveli. So here what we have used is, we have used 4 different donor eyes. Among them, 2 were our own patients who had primary open angle glaucoma for more than 20 years. So this was their IOP in their last visit, and you can see that the posterior segment is also significantly affected. When the cup disc ratio is above 0.7, then it indicates that there is a glaucomatous condition. So now here you can see it is 0.9 and 1, wherein there is a severe glaucomatous condition. The other 2 patients or the donor eyes were from other, we were treated in some other hospital, not from Arvind, but we confirmed that they are primary open angle glaucomatous patients based on the histology of the posterior segment. So we did again immunostaining for ABCG2 and P75. So this is the age matched control, wherein you still do see, even at older age group, we do see some ABCG2 high positive and P75 positive cells, whereas in glaucomatous condition, we do not see any positivity. So this is what is reflected here in the data. So the total TM cell count decreases significantly in glaucomatous donor eye compared to age matched control. In parallel, the percentage of the stem cells were also significantly reduced in glaucomatous condition. So this indicates that there is a need for stem cell therapy for glaucoma. So when we looked at the literature, people have started using the bone marrow derived mesenchymal stem cells or trabecular meshwork stem cells in animal models or organ culture models, and they have demonstrated that there is a trabecular meshwork regeneration. And in mouse model, when they transplanted the cultured trabecular meshwork stem cells, they demonstrated that they home to the trabecular meshwork. And similarly, the iPSC-derived trabecular meshwork stem cells, they are also demonstrated to restore the trabecular meshwork homeostasis through integration as well as paracrine effect in animal as well as organ culture model. So what we did in addition to that is we used the adult tissue resident stem cells, the trabecular meshwork stem cells, and we try to see whether this is useful for our patients using the organ culture model. So we use the human organ cultured anterior segment, which is HOCUS in short. So this is an ex vivo model for glaucoma research. So this was originally developed by Johnson et al. In 1987. And this organ culture model is an intermediate between cell culture and whole animal model. So here you can see the anterior segment is dissected out from donor eyes which are not suitable for transplantation. And then we have the fluidic system by which the pressure can be controlled. So here you can see the whole setup. So here the inside the CO2 incubator, you have the anterior segment in culture, and the syringe pump and pressure transducers are used to facilitate the flow of the medium through the anterior chamber. So this HOCUS model, it offers a unique opportunity to study the physiology, biochemistry, and morphology of the outflow pathway in viable tissues. So this is why we use this HOCUS model to study the effect of stem cell transplantation in this model. So in order to establish a glaucomatous condition, we established a cell loss model. So we established the cell loss model using saponin treatment. So normally in a glaucomatous trabecular meshwork, there is around 36% cell loss. This is what is reported. And we also did a saponin treatment, and we used different concentrations of saponin, and we found that 0.002% saponin to cause 30% cell death. So this was almost equivalent to the glaucomatous condition. So we used this concentration of saponin as we established in the cell culture model. We use the same thing in the human organ culture model. So here when we used saponin, so here you can see that there are more number of tunnel positive cells, which is around 27%. So this percentage of 0.002% saponin was also equivalent to what we did in the cell culture model. So when there is a loss of trabecular meshwork cells around 27%, we found that in such eyes, the intraocular pressure was also increased. So with the loss of trabecular meshwork cells, we also demonstrated the data I have not shown here. When we did the staining for ABCG2 and P75, we found that the expression of ABCG2 and P75 was lost in these eyes after day 7, and therefore we demonstrate that the loss of trabecular meshwork stem cells and loss of trabecular meshwork cells and also results in increase in intraocular pressure. So thus now we have a cell loss model for glaucoma. So using this model, we wanted to see whether transplantation of cultured human trabecular meshwork stem cells can help in restoring the intraocular pressure. So for this, we decided that we can infuse the cultured cells into this model and see the effect. So to do that, we established the trabecular meshwork and the trabecular meshwork stem cell cultures, and we characterized them. So we used the corneoscleral rims from the donor eyes, and then we dissected the trabecular meshwork, did a collagenase treatment, and we cultured in different media. The trabecular meshwork media, it normally differentiates them, and the stem cell growth medium maintains them. So this is based on the literature. So which we confirm by characterizing them from primary to passage 3 for the phenotypic expression and functional characterization, phagocytosis, response to corticosteroids, and spear formation. So here you can see that the cells grown in the stem cell growth medium after 21 days of culture, they were very small and compact compared to the cells that were grown in the trabecular meshwork medium wherein they get differentiated. So this was again confirmed by the expression of CD90 and 105. So here we find that till passage 3, it is maintained better in stem cell growth medium. And most importantly, functionally, when we see the spear forming ability is there mostly in the cells that were cultured in the stem cell growth medium. And both the cultures had the ability to phagocytosis. So the stem cell growth medium was identified to maintain the stemness with functional efficacy. So using these conditions, the stem cells were cultured and then they were transplanted onto the Hocus model. So when we transplanted and followed it for 7 days after transplantation, when we checked the tissues after that, we see that these cells, these transplanted cells, are labeled with Q tractor. So these Q tracker dots are, they are tracker dyes, and they will appear red in color. So we found those Q tracker positive cells, they to be positive in both the filtering and the non-filtering region. And we also found more of proliferating cells here. 1 second. So this is the Q tracker data. So here you can see the presence of the cells having the Q tracker both in the non-filtering as well as the filtering region. You can see those positive cells. So we also found the expression of ABCG2 and P75. As I said, ABCG2 and P75 are more in the non-filtering region, but when you see the section here, you do see the transplanted cells which are highly positive for ABCG2 and P75 to be present in both the filtering as well as the non-filtering region. So there is no specific integration of these stem cells to the non-filtering region. You see them both in the filtering and the non-filtering region.
Okay.
So then, when as I specified, you do see more of proliferating cells in the trabecular meshwork. And when we looked at the intraocular pressure, so the black graph line shows the saponin treated eyes that also received the stem cells, and the red one is the saponin treated. So here, if you can see, after saponin treatment, the IOP increased in both, and this is after 24 hours of saponin treatment. The cells were transplanted, and then you see that the eyes that were treated with the stem cells, there is a reduction in the intraocular pressure. So this gave us the proof of principle of a stem cell based therapy for glaucoma. So this is the paper which we published, and the next half of my presentation, I am trying to summarize the work that we have done so far. As an alternate to stem cells, can we use exosomes or the small extracellular vesicles to develop a cell-free therapy for glaucoma? So the exosomes, they are very small in size, and there is a minimal risk of immune response or tumor formation, and they are stable. They can be stored for a long term, and they can be easily transported. There's no ethical issues, and they can also be engineered to deliver specific cargoes. Because of these, the exosomes have emerged as a major player in regenerative medicine, particularly with mesenchymal stem cells. So what are these small extracellular vesicles? So these are secreted by almost all cells in our body, and they are lipid bilayer non-dividing nanovesicles. They carry the physiology altering biological information in the form of proteins, nucleic acid, lipids, and metabolites. And they can act on proximal cells or distal targets, and they are immunologically silent. As I said, they are stable in circulation and can also be engineered to carry modulators. So we wanted to see whether these trabecular meshwork stem cell derived exosomes can be used. Before starting that, we also looked at what are the clinical trials that are now going on using exosomes, particularly with reference to eye diseases. There are 12 clinical trials on exosomes and 5 on mesenchymal stem cell derived exosomes. So this gave us confidence that exosomes can be alternate to the stem cells. So we started culturing the trabecular meshwork stem cells and started isolating the exosomes. So we have the primary cultures, and we collected the conditioned media from these cultures. So more specifically, we need to use exosome-free fetal bovine serum. And then from the conditioned media, we isolated the exosomes or the small extracellular vesicle using ultracentrifugation. And then we characterize these extracellular vesicles or the exosomes. So these exosomes, as I said, they are smaller, around 30 to 200 nanometer in size. So our exosomes were around 162 nanometer in size in an average. So this fell in the allowed range. And then when we did the TEM analysis, they had the typical cup-shaped or spherical morphology here. So this is from the trabecular meshwork cells, and this is from the trabecular meshwork stem cell. And when we did the Western blot for the expression of markers, syntonin, CD9, and CD63 are common markers for the exosomes, whereas neurophilin and amylin are specific for trabecular meshwork derived extracellular vesicles. So these were all positively expressed in both the trabecular meshwork as well as the trabecular meshwork stem cell derived extracellular vesicles. And this GM130 is a negative marker, so it was negative in both. So by these three methods, we confirm that we have isolated the small extracellular vesicles or the exosomes. Then we went on to do the functional studies. Functional studies included uptake assay, in vitro scratch wound assay, as well as chronic oxidative stress condition. So when we started with the uptake assay, we used different types of cells, the trabecular meshwork cells. This is a lens epithelial cell line HLE-B3 and 3T3 is mouse myofibroblastic cell line. So you can see that the exosomes, both trabecular meshwork and stem cell derived exosomes were taken up by all the cells. But if you look at the degree of uptake, it differs. So you can see the trabecular meshwork stem cell derived exosomes were taken up more by the trabecular meshwork cells. There is some amount of specificity. We still do not know what is the reason and what is the receptor that is there that is responsible for this specific uptake. Then we went on to the wound healing property of these extracellular vesicles. So here you can see the control, positive control, the trabecular meshwork derived exosomes and trabecular meshwork stem cell derived exosomes. And this is at 48 hours. So we see a complete closure, almost a complete closure in the stem cell derived exosomes at 48 hours, which was equivalent to the positive control what we have used. So this was much quicker compared to the trabecular meshwork derived exosomes. So thus it has a high proliferative potential. To confirm that, we immunostain the cells for Ka67. So here again you see more of Ka67 positive in the stem cell derived exosome treated cells. And we also did immunostaining for BRDU because BRDU stains only the actively proliferating cells. So here again the BRDU appears green here. So these cells were higher in the cells that were treated with the stem cell derived exosomes. So this indicated that exosomes, the stem cell derived exosomes enhance proliferation of the cells and hence in the wound healing property. The next major functional assay that we checked is the antioxidant potential of these exosomes because in trabecular meshwork, particularly in the glioblastoma condition, oxidative stress is one of the characteristic features. So we wanted to check the antioxidant potential of these exosomes. So we treated the trabecular meshwork cells with hydrogen peroxide, different concentration, and we found that 100 micromolar is a suitable one to check. And then when we treated these cells under oxidative stress with the exosomes, we found the stem cell derived exosomes to enhance the antioxidant potential. This we also confirmed it with the staining for the intracellular ROS production by DCFDA assay. So here you can see that there is a reduction in the number of ROS positive or the DCFDA positive cells treated with the stem cell derived extracellular vesicles. So now we have shown that the exosome that are derived from the stem cell has high proliferation potential and also has antioxidant potential. So we are now started or culturing the cells under xeno-free condition and isolating the exosomes which will be of use for clinical application, following which we are planning to go with the animal studies. So to summarize, we demonstrated that the trabecular meshwork stem cells are there in the anterior non-filtering region, and with aging there is a reduction of trabecular meshwork stem cells which was significantly associated with the already reported trabecular meshwork cell loss. And in glaucomatous condition, there is a much more or a drastic reduction of trabecular meshwork stem cells as well as trabecular meshwork cells, which might be responsible for the increase in intraocular pressure and optic nerve damage. And our HOCA studies indicated that transplantation of trabecular meshwork stem cells resulted in integration of these cells as well as reduction in intraocular pressure. And our in vitro studies using the stem cell derived exosomes demonstrated that it enhanced EM cell proliferation and wound healing property, as well as it had the antioxidant potential. As I said, now we have established a steroid induced glaucoma mouse model with the help of our collaborator at BITS Pilani Hyderabad campus. And we are now trying to see whether transplantation of the stem cell derived exosomes can help in restoring the normal IOP as well as have a neuroprotective effect on the retinal ganglion cells. So this is our team, clinical team, Dr. Krishnadas sir and Dr. Shanti ma'am. And at AMRF, as sir said, Professor Dharmalingam sir is our director and he has been the guiding force and a great inspiration for all of us at AMRF. And he was the main person who established the Exosome Innovation Center at AMRF. And all the exosome work was possible only because of him. And Dr. Barnitharan is our bioinformatics person who has helped us a lot with the data analysis. Dr. Sendil Kumari, who heads the ocular pharmacology department, had helped us with the HOCAS experiment. And this is our team. And Dr. Nirmal is our collaborator who has established the animal model now and will be carrying out the transplantation of the stem cells as well as the exosomes to see its effect on the reduction of intraocular pressure. So before I conclude, I'd like to thank ACRB, ICMR, CSIR UGC Net for the fellowship, Lady Tata Memorial Trust for the JRF fellowship, and Sun Pharma for supporting us the exosome work. And we acknowledge the support from Rotary Arvind International Eye Bank Madurai as well as Coimbatore and Tirunelveli for providing us with the tissues that are required for the study. And before I conclude, I'd like to conclude with the words of Dr. G. Venkataswamy, our founder. Intelligence and capability are not enough. There must be the joy of doing something beautiful. Thank you.
Thank you so much, ma'am, for a wonderful presentation. It's a really eye-opener for the work which has been done in the ophthalmic. Thank you so much. Over to Dr. Ravi.
Yeah. So thank you, madam. As usual, it was a very lucid explanation of the basics behind the pathology and how you have addressed to correct the pathology. One question, madam. I think you are saying that you are trying to go for animal model with the treatment of exosomes, or are you going to do with stem cells also?
Both, sir. Both we will.
Both your. So this glaucoma model, you are going to do both, or
So the glaucoma model is going to be only steroid. Only steroid. Yes, sir.
Steroid induced, and you are going to try both the stem cells as well as the exosome.
Yes, sir.
Oh, okay. Thank you. Because the stem cells are already available. So in India, stem cells are already approved, and so we have already got the stem cells. Now we can. It is easy to use an available product, so you can get a clinical grade product straight away. Whereas
Yes.
for exosome, till today there is no approval. So if you are going to do it, you will be the first person, first team to establish that exosomes can correct a pathology, and then it can be clinically brought out through the phase 1, phase 2, phase 3, and then we will get a drug, exosome as a drug. So thank you very much, madam. When you are doing both, we are very happy. If
Yes,
you are
sir.
doing only exosome, I will not be happy because this stem cell is already available, and meanwhile we can treat the patients with stem cells if the proper regulatory things are approved. So they are readily available. And when you come out with exosome, that will be the first. You will open the floodgates, and then the others will follow, and then exosomes will be useful for so many other pathologies also. So thank you for the excellent presentation, madam.
Thank you, sir.
Anybody else has got a question, please?
Yes, ma'am. Yes, sir.
Can I ask one question?
Yes, sir. Yes, please, sir.
Ma'am, I was working with the exosomes, rather we work with exosomes at Stemarex here, and we could find out one of the transcription factor, which is PROX1, which is playing a major role in lymphangiogenesis, generation of the lymphatic. vessels, when loaded with exosome and locally using polymer, OP polymer, PMDMEAM, which gives a penetration up to the subcutaneous tissue. Now, these exosomes with PROX1 we have seen in animal model developing the Schwann canal again back.
Okay.
And the next level I would love for you to enter in this research where the local application on the middle canthus of the eye for 10 to 15 times in a month time, you will see the IOP pressure absolutely releasing with the re-establishment of channels back again lymphatics.
Okay, sir.
And this help two ways. It will help to reduce the pressure on the optic nerve, as well the benefit of the glaucoma treatment without we call as a complete transcription of lymphatic channels using this transcription factor.
Okay, sir.
I mean, since you have done such a wonderful work, if you can add to your work this, probably this will be a mind-blowing work for the ophthalmic industry.
Yes, sir. Yes, sir. Sir, are there any publications
you.
from your site, sir, which I can look into?
I'll send you the links of what we have done it.
Yes, sir. Yes, sir.
Animal.
Yes, sir. Yes, sir.
And then I'll take. Can you note down my number?
Yes, sir. Yes, sir. Please, sir.
8898
8898
070904.
Yes, sir. Yes, sir.
This I'll send you a complete literature.
Yes,
this
sir.
will be a next level of work for you because you are running an ophthalmic institute. You have been such a wonderful work. I'm working in general regenerative medicine center, but yours is a focused, passionate work. And as such, Dr. Founder of your Venkatesh, he has said you knowledge and intelligence and hard work is not enough. It has to be done beautifully with the passion. So you're already doing. Just add this molecule to you and you will see entire ophthalmic picture changed.
Yes, sir. Sure,
Thank you, sir.
Thank you.
Thank you, sir,
Thank you so
Mahajans.
much.
So this is what we really want. So as he said, it is not only enough to reduce the pressure at the trabecular meshwork. You should also address the pathology in the back of the eye. So unless we do both, the patient is not going to benefit. So as Dr. Mahajan said, madam should look into the retinal side also and then establish that so that the treatment becomes complete.
It's true, sir.
Dr. Gauri, I'm confident that you can do at your institute.
Yeah.
Yes.
Whatever you require a backup support on this, on retrobulbar area, we can support you. I can
Yes, sir.
support you procurement of these molecules of clinical grade. I can support
Yes, sir.
you loading in the exosome. I can support you making and gel to just locally apply on the medial canthus of the eye,
Yes, sir.
which will be absorbed locally. So there is no injection, there is no cut, nothing doing, and 100% safe because you are locally delivering everything locally.
Good.
Yes, sir. Sure, sir. I'll be in touch with you, sir.
Thank you, ma'am. Thank you. You can just say me hi on WhatsApp.
Yeah.
Thank you.
Thank you.
Thank you so much. Thank you so much, Dr. Mahajan, sir, for your nice comments and directions. Thank you so much. Over to any other questions?
I have a question.
Please.
Yes, sir.
Of course, wonderful presentation. That's my words. So, what Mahajan says it was right, but what I'm saying, I mean, I want to ask one question. How do you place this product, man? Is it going to be daily application? It's going to be monthly or yearly? Because you must be foreseeing this, right? Because you're
Yes.
having a pharmacologist team, you're having I mean, what will be the next stage in a drug formulation? Please explain us that.
Yeah, as you rightly said, we still do not know like what it should be the dosage, how frequent it has to be applied. That has to be worked out. So For the time being, we are just using this animal model to establish again the proof of principle for a clinical trial, but we will have to do the HOCUS again, the organ culture, the human organ culture model again, to check what will be the dosage that will be required for the human eye. That is one thing. And only when we go to the patient, we will be able to decide how frequent it has to be given. So this will be stage by stage. I think we need to address that, because whatever we are going to do in the animal model might not be the exact thing in the human as well. So it has to be the animal model, the human organ culture model, and then the humans, the clinical trials. I think this is what will define how frequent we have to do. And as Dr. Mahajan rightly pointed out, that's where people are now going to go more towards, like, you bioengineer these exosomes. Like, if you know which is the cargo, that is the next step. We are also parallelly working on what is the cargo that is within these exosomes, trying to understand the microRNAs that are there, the proteins that are there. So we are trying to look at all the various cargo that are there. And if you can identify the major cargo that is there, then we can go for a much more specific targeted therapy for glaucoma. So that is also going in parallel. But yes, sir, it has to go stepwise. We need to approach this.
Ma'am,
But
here
one
we
aspect
can.
of the question is, we understand this glaucoma is one of the leading cause of blindness.
Yeah.
But already we have quite good drugs which people apply. So where will this stem cell therapy fit in? Which you see that which patient will be benefiting from these patients in the early stage, or if for all patients? Please tell me.
So, as you say, we do have a treatment for glaucomatous condition, but this is mainly for those patients. We will start with those patients for whom no therapy is helping them. So, wherein no other treatment is helping them in restoring vision. So, those are the patients whom we will start with. So, then only we can come back to the rest of the patients. So, we
But why
feel
can't
like.
we see a different way, ma'am? Why can't we see a patient who is responding to medications?
Mm.
Why can't we see a drug-free period? Because that is where, when you think of regenerative medicine, people tend to choose a last stage, and they think that it is going to fail. Already it's a failed case.
No, that's where we are trying to see wherein this can help in regeneration. See, this has, as I was telling, antifibrotic property also. So that is what we'll be looking at. So, and ethically, when you are doing such clinical trials, the first thing that is approved is only for those conditions wherein no other therapy is helpful. That is the easiest one which will be approved for ethical issues. So that is the only thing that we can go for, particularly for those cases wherein, as you rightly say, the wherein the therapy is already there, where it is helpful. That will be the last option for us. So the first option is only for those patients wherein there is no therapy. So if we are successful in that, automatically the remaining things will fall in place.
Because this glaucoma is a chronic progressive degenerative disease of the stems. So if there is a disease modifying anti-rheumatic drugs in orthopedics, why it should be disease modifying anti-glaucomatous drug, where you can give it earlier, which can change the course of this disease? Because patients tend to give medication for 20 years or so. So
Yes,
I'm
sir.
just thinking loud with you. Maybe
Yeah,
we
yeah.
can think about more earlier we apply that. So better will be the typical or framework in the upcoming years for the patients.
Yes, sir. Yes, sir. That will be surely looked at, sir. Yes, sir.
Natish, usually what happens in CDSCO, generally they will give an approval as unmet need initially, which possibly Dr. Priya's group can do it, which will help them to prove the concept that these are the patients who are already losing the vision and there are no options.
That is true. That is true.
And once that is done, then it will become to, as you said very well, it can come into primary treatment also. That's what I feel the regulatory work will go. And also, ma'am, I can help you for one more thing. I can identify your exome cargoes, which are important, which are MIRs of different type and let P also of different type, which will be exclusively working to develop these lymphangiogenic targets and vasculogenic target.
Okay, sir.
And we have a technology also how to load them
Okay.
using sonicator technology or this electroporation. So these technologies we already developed. We also have their modern marker studies. We have also identified them what percentage of engineering can be done to load that. With 70%, 60%, 80% cargo can be loaded or identify that cargo.
Yes, sir. Yes, sir. Yes, sir. Thank you,
Nice
sir.
presentation, ma'am. Which
Thank you,
animal
ma'am.
model do you which animal model do you contemplate using?
It's a mouse model, ma'am. C56
It will
BL6
not be
mice.
easy. You can't catch a mice again and again to put eye drops in the eyes. And how
So
will
this
you
will not,
examine
yeah, this is
left
not going to be
anesthesia?
as eye drops, ma'am. So it will be intracameral injection. So that will be delivered once. So based on how the response is, then we have to see whether a second dose is also needed. So it's not going to be as drops, ma'am, as of now.
So you have a glaucoma model in the mouse?
Yes, ma'am. Now we have established, our collaborator has established the steroid-induced glaucoma model. So wherein he has demonstrated there is an increase in the pressure in these models. So we are trying to establish the whether there is a TM cell loss also, so that it becomes more suitable for our work. So that's what we are now doing in that model, trying to see what is the status of the trabecular meshwork cells as well as the stem cells. Then there is an increase in intraocular pressure, whether it mimics the human glaucomatous condition. So once we confirm that, then we will go for the transplantation.
You can try in rabbits also. Rabbit has nice eyes which you can easily see and
Yes, ma'am.
dilates and it has color. So
Yes.
you'll be able to see the things without even catching the rabbit.
Yes, ma'am. Yes, ma'am. Sure, ma'am. We'll look into it, ma'am.
Usually, the ethical approval is much easier for smaller animals. That's what I
But
understand.
rabbit also is not difficult. It's the next line. Once they see the
No, we
mouse,
can give that. We can, of course, as you say, it's big eyes, easy to inject
yeah,
it.
yeah, yeah. And it really responds. When I operate on rabbits, so when we give anesthesia, we can see it from the eyes. It's nicely dilating and then it's very responsive. You can see what all is happening inside the eye also. We can see the retina also through the widened pupil.
Yes, ma'am. We'll look into it, ma'am.
Madam, anybody coming to the iBank Association conference in Cochin, September 5 and 6 from Aravind Eye Hospital?
Maybe our IBank manager should be coming. I'm not sure. I'll check with him, sir.
Yeah,
But he
please,
is always in that group. He will be coming, yes, sir.
what is his name?
Mr. Sharavanan.
Okay. And that ocular pharmacology, you mentioned there was one person in the. So whether she will be also coming, you don't know.
Dr. Sendil Kumari, no, sir. I don't think she'll be coming because she's basic scientist who again is working on steroid-induced glaucoma using the focus model. She's working on that. So
okay. So I am going to there for that conference.
yes,
so
sir.
I think I will meet them. And then what about our FBS, madam? You are saying something about fetal bovine serum. I just heard that. Anything specific you wanted to avoid, like this fetal bovine serum, and then so
So
already
we are
have
now,
you tried?
yes, sir. We have now used the serum-free medium commercially available for collecting the conditioned media. So we are going with the commercially available stem-in-one medium, which is serum-free.
Is it human platelet lysate, madam?
That they are not specifying, sir. So these company people, they don't
You don't
reveal what
know.
is it. They don't reveal, except that they have specified that it is serum free. And we have also checked those for the presence of exosomes, whether they are there. So we use that as a control for all our experiments. Though we do see some nanovesicle-like thing, but they don't have any effect functionally. So all those things we have checked in our current study. We have explored all these things. Yes.
No, we had given you some samples.
Yes,
I'm
sir.
just
Yes,
waiting
sir.
to see and
Yes, sir.
hear it from you. Thank you.
Yes.
Thank you, madam. Thank you very much.
Yes, sir. Thank you, sir.
So any more questions, people can unmute and ask, or we can close session.
Yeah.
Excellent, ma'am. So thank you so much for spending your time. And you accept this invitation on very short notice, irrespective of your busy schedule. Much pleased, ma'am. And we want a request from our side. We want you to bring more people into this region of ophthalmology, where more scientists, where we can sit and discuss, we can publish some consensus based on this. So this field should grow.
Yes, sir.
That's what I'm saying, because people should understand their research prospects in this field, and they should be able to come forward and initiate discussions. Because 5-10 years from now, we can see so we're going to modify the disease progression of this chronic degenerative disease of eyes. Then it is a game changer for people. So the actual unmet need is inability to cater more eyes for the people who are blind. This is the real unmet need. So this can actually meet that. Barring all indications. So once again, ma'am, thank you so much. Thank you for being
Thank you, sir.
For the guest of our journal club. So we will be having next session in next month. We invited an international speaker for the session, and hopefully we'll be having it on September. I believe it is 18th. As of now, we have confirmed that.
Okay. Okay, Nitesh. Thank you. Thank you so much.
Thank you so
Thank
much.
you.
Thank you so much, Dr. Nitesh, for a wonderful.
Thank you, sir.
Thanks a
Thank
lot.
you, sir.
So much.
Sir, one announcement. So I am trying to arrange one IMA meeting at Pollachi, Indian Medical Association, where I am trying to have a session on regenerative medicine. So once if it is confirmed, I will post that in the group so that we can include it in the Indian Stem Cell Study Group Associate website.
Definitely, sir. Definitely, sir. We'll do
Okay, thank you.
Thank
Thank
you.
you, sir.
Thank you, sir.
Thank you, everyone. Thank you for
ma'am.
active participation.
Thank you, everyone.
Thank you so
Thank
much.
you, ma'am.
Good night.